And now I invite Dr. Murali ARIGA to talk to us and tell us on how to anticipate risk in ophthalmology and how to manage them. So risk assessment and preparation for the risk is essential to avoid or prevent the risk. So over to you, Murali, for telling us about the medical legal risk in ophthalmology.
Thank you, Dr. Nirmal. And at the outset, I would like to state that this is an awareness talk, and the examples I quote are not intended to target any individual or institution. And the first and foremost we have to understand about the law and health is that the right to health is recognized as a fundamental right in Article 21 of the Constitution. So therefore, this is various acts, Constitution, the acts of Parliament, legislation, pronouncement of the case laws, international laws, and WHO. So health is considered to be a fundamental right. So the state has the right to frame laws, and we have to abide by them. That's the first thing. So we are dealing with health, ophthalmology or otherwise. So health is the most important part of a fundamental right. So you don't have much say about what the government decides and what is the law. So first and foremost about the health and the law is that this question came up recently about, can we choose a patient for treatment? You are sitting in your practice and the patient walks into your clinic. So can you accept a patient for treatment? Can you provide the treatment? You complete the treatment. Do you have a choice of not accepting? Can you refuse a particular patient? Yes, you can refuse a patient for treatment, provided it is not an emergency. But in emergency, you have to accept all patients for treatment. So this emergency is actually a gray area. Our societies, for example, our state society or the national society, we have not decided what is an emergency. Is acute headache an emergency? Acute glaucoma an emergency? Foreign body in the cornea is an emergency? Vitreous hemorrhage is an emergency? Vitreous hemorrhage of 3 months is an emergency? So we have not actually defined what is an emergency. Therefore, a lot of gray areas are there. So we are bound by law to treat any emergency, whatever is considered to be an emergency in the public eye, in the best of your ability, to the best of your ability, good faith, reasonable care, a prompt referral if you don't specialize in that, without any monetary consideration. That's the catch. So everybody expects us that we are all millionaires, we're all earning, minting by the minute. So therefore, we need to provide treatment as an emergency. This, I think you must have all seen this scary news about right to health. Anybody can walk into any practice and say, I have a headache for 6 months. I have an acute emergency now. You see me right away. Private hospitals, government and private hospitals have to do that. So that is the problem with the. So luckily, this was rolled back and is not brought into a national level. So right to health in private practice. The government has institutions. The government can take care of all emergencies. Where is our subsidy? Where is our sort of incentive to do free work for emergency cases? We can probably provide first aid, but not really start the full-fledged treatment for any kind of emergency. So I think Dr. Nirmal had mentioned about how our profession is regulated. We are heavily regulated. We have lots of laws, lots of things which we had to abide by. Previously, it was the MCI. Now it is the National Medical Commission. And we have various boards under that, especially the Ethics and Medical Registration Board, which is now slowly coming in, and we all have to abide by the rules. And of course, the current ethical regulations, what we have to follow is the Professional Conduct, Etiquette and Ethics of the 2002. It has been amended several times. Recent amendment has been in 2016, 2017, 2019. So I think all of us have to go through some of the aspects of the ethics and code. And this is the what is currently, just a very brief summary of what is, all of us when you sign our Hippocratic Oath, this is what we actually sign for, about the ethics, about duty of physicians to our patients, to physicians to each other, physicians to the public and the paramedical profession, and we should not be indulging in unethical acts and misconducts like advertisements, media, going in. A registered medical practitioner cannot go in and solicit patients, whereas a hospital or a corporate can do so. So a registered medical practitioner should not accept gifts of a certain quantum of money, and certain receive commissions, cutbacks, employers fee splitting, employing touts, and not compelling patients and doing what is called a tide selling. All kinds of acts and laws are available. So we should understand various aspects of how we practice. So we understand that suddenly we realize that we have done something which is now coming under an act of Parliament in which we should not have done that. And the Ethics Committee as well as the the rules and the guidelines now tell us that medical records slowly we have to move towards, or if you have not done so already, please move towards digital records, electronic health records. And all physicians must maintain copies of the records of all inpatient records for at least 3 years. That's the current regulation now. Certain states, certain hospital protocols may vary, but the minimum absolute is 3 years. 3 years, 5 years, 10 years, we like to keep it for all of the records of however long you've been practiced. That is good. So try to digitize, try to keep it electronic, try to maintain all records. The CEA actually has specified that. And anybody who asks you for any kind of a summary or a record of what treatment you have provided to somebody, the treatment you must provide within 72 hours. That's the current regulation. And also, we all know that currently most of us, hospitals, clinics, we are all regulated by the Right to Information Act. Somebody can write to you under the Information Act and ask for demand for information from your hospital as to what is going on in your institution. So the RTA is now applicable to hospitals as well. It's not just only private clinics and everything else. And all of our labs, all of our primary healthcare, hospitals, pharmacies, everything better to go in for digitization. I think we must avoid, as colleagues and among our, we see, can anything be made out of this? So we all like smile, say a doctor's handwriting, and we all say that this is the way it should be. So but we really have to move beyond this, and we should correct ourselves and correct our own colleagues and ourselves, make it legible, make it right in hand, and also the prescription of writing generics. So the government is coming down heavily on us because of this reason, that we should prescribe and write only generic medication. There are limitations because there's a huge cost difference between what is generic and what can be a branded medicine. So there is an out-of-pocket expenditure for the patient, and I think we are justified in probably to an extent, large extent, recognizing a patient's inability to pay for something and then prescribe a generic if possible. I think you're all aware of government opening up these pharmacies all over the country now, where they sell only generics. So the professional conduct review, this is a recent publication, a press release from the National Medical Commission. I'm not sure all of you have seen this. This is a very important document. You must see some examples, case examples. I'm going to quote a few examples from this. The professional conduct review has shown about 10 examples of what have been litigation, what has come out as outcomes in the consumer forum, and what we can learn from them. I'll give you one example from the same professional review publication. Dr. R was practicing as a consultant sonologist with a 6-month training certificate according to the PCPNDT Act. What happened is he started performing ultrasound for other illnesses beyond the scope of his certificate under the PCPND Act. The local IMA took cognizance and filed a complaint. After deliberation, they removed his name from the state medical register for 2 months and asked him to refrain from practicing as a so-called consultant sonologist. He was practicing as a radiologist sonologist with a 6-month certificate under the PCPNDT Act. And then despite this order from the State Medical Council, he continued to perform ultrasound for other indications beyond his training and still use the word consultant sonologist. So he appealed against this in the Honorable High Court, and then which they reacted to the National Medical Commission, which again pronounced his verdict and said that you have to give an undertaking that you should not practice beyond what you have been qualified for, and do not use the term consultant sonologist. It confuses the public. You have only undergone training just for this particular act alone for 6 months. You cannot become an... and then similarly, another example of what we should do and what we should... I think I have time for 15 minutes, I think. Timer is set wrong. The ethical regulations specify that a physician should not claim to be a specialist unless he has a special qualification in that branch, according to our professional conduct, the 2002 regulations. So therefore, we cannot practice beyond your specialty. You cannot practice cardiology, you cannot practice obstetrics and gynecology. Maybe you can treat an emergency and immediately refer out to somebody. Don't profess or don't claim to be a specialist in what you don't have any training for. For example, if you are a cornea specialist, you must have had some subspecialty training, some proficiency in that particular specialty. And do not affix signboards on chemist shops. Do not put in places where you don't work. You can't put up names and signboards in those kind of places. So this is another example of a urologist who treated, this is again from the professional review board examples. This is where the case went through. Patient had a ureteric stone. The stone was removed by a qualified urologist, and his associate gave a discharge summary which did not specify which method of surgery was done. And the surgery, when he went to another doctor, they found the stone was still there. So they claimed that the stone persisted, and this PCNL and this RIRS was done. The consent was taken for the same, but the summary did not mention what procedure was done, and the junior colleague did not document it in the medical records. So there was a discrepancy between the procedure done, the operation notes, the statement given in the online hearing, and therefore his name was removed from the register. This is a fact. This is what has happened. Even though you're a qualified urologist, you've done the procedure, this kind of discrepancy was there in the operation notes, and the statement given. The discharge summary did not mention what was done. So what was stated, what was in your notes, and what is in your discharge summary has to correlate. And it can be your associate. Your associates are also liable under you. So they become vicariously liable. All your staff are vicariously liable. You are the boss. Suppose you are the person who is the main surgeon. Whoever makes a mistake and works under you, you have to take responsibility for that as well. So document the communication and communicate the documentation. So the doctor did not document the procedure. There was inadequate communication as to what was actually done. There was a discrepancy, clear discrepancy as what was done and what was given to the patient. And do not make negative statements. One doctor who saw the patient subsequently has made very adverse negative comments about the previous surgery, saying that the stone is still there. Has he removed it at all? I can still see the stone there, and so on. These kind of negative comments to patients about clinical judgments and the procedures by other colleagues, and therefore we need to have trust in each other. We need to have belief in each other. We have to hold hands. We are a fraternity. We have to hold hands and do not demean another professional. What exactly went on in the other hospital, nobody really knows. He could actually prove that he had actually done the procedure and he had actually removed the stone, but it could not be proven with the documents available. So that's the problem. The CA, I think Dr. Nirmal has mentioned about the need for CA, and primarily this is actually a crackdown on quackery, so we really need to appreciate the government's efforts to bring in the CA, so only qualified professionals can actually practice. But what is important about the CA is the treatment guidelines. You look at the website of the CA, you will find there are treatment guidelines even for ophthalmology. For so many subspecialties in ophthalmology, also like cataract, glaucoma, retina procedures and all that, certain guidelines are available. You have to abide by the guidelines. For example, if they say a blood sugar of 200 or less has to be kept in place for your cataract surgery, you must follow that. So these guidelines are important because these are more used by our advocates and the legal professionals who look at these guidelines and say you didn't follow that. We actually don't look at much of these guidelines. So consent, I think Satyan had pointed out about the various aspects of consent, the implied consent, the express consent, the doctor's liability. Suppose you do a procedure without a patient's consent, you are actually liable under civil law for tort law for battery. You have assaulted the patient without the patient's consent. And for suppose you have done something which has endangered the life and caused some grievous hurt, some complications happened, you are liable for criminal negligence. So therefore, consent is a very important aspect. You must, I think he quoted this example, a very famous case of a consent given for a specific procedure about not being valid for something else. You have taken a consent, express consent for one particular procedure, and suddenly you decide to change it on the table and you go back and inform the patient or the relative after the procedure, it is not valid. Unless it's a medical emergency or a life-threatening emergency, do not do it. Suppose you need to stop, you stop operating, go back, get the consent, come back another day and operate. Don't do procedures which you think is good for the patient in good faith, in your own opinion, you feel the second procedure should be done. Don't do that. Always stick to guidelines. For example, this is an example of maybe a few years ago, we had a patient who underwent a YAG-PI and went in for a total hyphema, corneal decompensation, raised IOP, went in for a legal notice and then is still in court. But the consent did not include bleeding can happen after YAG-PI. How many of us take consent about YAG-PI? How many of us inform the patient the bleeding can occur? It can be 1 in 1,000. But if this happens to your patient, so what can happen? So we make sure that everything is like he mentioned in the consent. Mention all the possibilities, all the common possibilities, what can happen. Explain to the patient what are the alternatives and what are the, suppose you don't do a YAG-PI, what can happen to a patient. So make sure you explain all of this, the alternatives, not doing it, consequences, and complicate. For some reason, the patient is not willing to sign the consent, do not do the procedure. Simple as that. Don't push yourself and say, this is good for you, I'm going to do it for you. Don't do that. Stay safe. Consumer Protection Act, I think the VP Shanta case is the landmark case. There was an amendment in 2019 which said that the medical services, somebody misinterpreted that medical services would be removed from the ambit of the CPA. It is not true. Medical services do remain under the ambit of the CPA. Even the recent Supreme Court has come out heavily and says that the doctors will remain under the CPA. We continue to remain liable under the CPA for medical negligence. So medical negligence, you have civil and criminal. Criminal is what we all sort of concerned about. Suddenly some complication occurs. Even an endophthalmitis after cataract surgery, people go to the nearest police station and say there was negligence. So a complication is not negligence. A complication is not criminal negligence. A doctor is held negligent only when his or her treatment is not in line with, he was pointing out about reasonable standard of care. What you have done is following standard of care. What is you have done is result in a legal injury, and there has been some damage done to the patient. So only then you are negligent. Only then, if you are criminally negligent, where the negligence has to be of a gross nature, really gross nature. That's when it becomes a criminal negligence. Don't worry about criminal negligence. Most of what we do is routine stuff. Most of complications we face is not negligence. So you have to understand. But however, we are liable. Suppose somebody wants to dispute what you have done, they can go to civil court, and the consumer forum is the most convenient for everybody. So this is an example, I think, of a doctor committing suicide because of a complication of a gynec obstetric procedure. And what has happened is, and this was actually a lot of hue and cry about this, because the police station took cognizance of a complication of a gynec surgery and went in and tried to arrest the doctor. The doctor committed suicide. So basically, it was just a complication of surgery. The police had no business to file a FIR. This was in Rajasthan, and the Rajasthan police had booked a FIR. But this is true negligence. True negligence is when you're screening for ROP, and if you missed it in the first month, 2 months, 3 months, and the baby loses vision, temperature normal, pulse normal, but what about the eyesight? Have you checked the baby's fundus? So this is a very important aspect. I think Satyan also pointed out about huge compensations are given because the child is very small. The compensations can be huge if you miss it. So make sure you follow the protocols for screening in these kind of diseases. Don't make mistakes. And this is a very common news item we will see about botched eye surgery. This is a newspaper's famous headlines. Everywhere you will see something happens as a complication, cataract surgery in camps, botched eye surgery. But sometimes there can be gross negligence, like one hospital discovered in this case in Trichy, about a large number of patients who lost vision, and running the hospital without taking legal consent from the pollution board. Improper design of the operation room, no separate room for sterilization. The CBI was involved in this. CBI got involved, people who are held criminally negligent, and a huge amount of fine was imposed. There was no appointment of an anesthetist here. The hospital is functioning without a lab for those particular camps, and the common things were not checked. No staff for sterilization. The infection was not reported. All kinds of things went wrong with that particular situation. Therefore, we really don't have defense if you're not following these kind of guidelines. So follow the NPCB guidelines. If you are doing camps, if you are doing cataract surgery in camps, make sure you follow the NPCB guidelines, stick to the protocol. This is an Arvind model, is a fantastic model of how you maintain quality in community eye care. So follow these guidelines and don't cross the line. Exceptions, confidentiality, I think I'll skip this. I think just an example of, we all assume that you can do an HIV testing for cataract surgery. How many of you do HIV testing for cataract surgery pre-op? Most of us do. So what we do you know under the law that you have to disclose the patient that you are testing for HIV? You must take consent from the patient before you test. All kinds of guidelines you have to follow. So make sure you understand the law before you go through that. And this is an example of a case in which patient was given an intravitreal injection and had a vitreous hemorrhage following a very casual Avastin injection was given. The patient has complained in court. The doctor was engrossed in conversation during the injection. He was making a casual comment talking about some news or cricket or some business, and the compensation was 1 lakh. So purely because there was a vitreous hemorrhage and a casual conversation was there. This was done in the newspaper. Not even in a, this has been public, now the doctor has been held up because of this particular complication. So I think this is also clear that what is, this need not have any explanation at all. You leave behind bits like this. This is particularly for my specialty of glaucoma, where we leave behind small bits of mitomycin swabs, like how you leave behind like this. The thing speaks for itself. You don't have to say anything. This is gross negligence. You can't do that. So I think he mentioned about the NCRD's 942 cases, the National Consumer Forum. This was published. 942 cases of medical negligence decided by the NCDRC, and of these 30 were related to ophthalmology. 73% of the alleged cases of negligence, it was proved, and the compensation ranged between 2 lakhs and 10 million. So be aware that ophthalmology is serious business, and the maximum number of cases, by the way, was from Delhi. The recent laws, we have to understand many laws, many laws. Now I think Mr. Nirmal was pointing out the Telemedicine Act, the PCPND Act. During COVID, what happened was a lot of laws were there. This also we have to understand there's a lot of violence against our healthcare professionals and our workers who work with us, even our nurses and paramedics. And all of this is considered to be violence. It's not just physical violence. The main thing we find is a trust deficit, the lack of communication. The cost is a big problem. Suppose we state some particular amount for the procedure and the cost escalates. This is where most of the arguments come. Cost escalation is a big thing, so make sure you handle that properly. Crowding, congestion, overburden, lack of communication is on top of the list. So this is the primary thing. Many of the laws dealing with healthcare workers, there is no specific national law for doctors. Understand that there's an ordinance passed, there's a bill that fell through. Only certain states have some Medicare prevention of violence. Tamil Nadu has one, many other states have. So state-specific laws are available, there is no national law. So most of our advocate friends and lawyers would tell us, avoid the circumstances that lead to the violence, and deterring such acts is very important. So put up boards like this in your practice. Say you're on camera, be aware that we do not tolerate these kind of violent acts. So make sure you take steps to deter the violence. Handling the violence after it has occurred is very difficult, and you really get the compensation which you get is pittance compared to what loss has actually happened. So make sure you avoid the circumstances, take deterrence. And of course, this is very important, take indemnity insurance. Malpractice insurance will be a safety net to help you in the lawsuits. I think the IMA PPLS, I think Sendil will talk to us about the IMA PPLS schemes and about the AIOS2025, which has now come in. And ensure adequate coverage for your specialty and the practice size, and review your policies periodically. So document everything, communicate well, have checklists and protocols like the NABH protocol. It's very, very important to be safe in practice. Do not step out of your guidelines. Keep to ethical practice. Stay united as a fraternity, and make sure you are part of membership of your local organizations. And all of them have legal cells. Like we have one in Tamil Nadu, we have one for the national AIOS as well. Take help from the legal cell, and don't sidestep, and don't think that, okay, I think you all understand what this means. Nirmal also pointed out this. Ignorance of the law is no excuse. Think that I don't know about some act or something in what has already been established by law. You don't understand that is no excuse for you to practice. You have to understand the law. We need to understand under what we work under. Thank you all.